Hey everybody, it's Mike Hanley. Trying something new this week. Going to try recording my didactic and then come on in and give you a case-based lecture over the noon hour. Be looking for feedback on how this compares to the other way. Today I'll be talking about critical care imaging and ICU, kind of a lines and tubes talk. Wanted to quickly just introduce ACR appropriateness criteria. Arun talked about this the other day at one of his quality meetings. Important thing to know about is about 200 articles about every topic: headache in the ED, abdominal pain, chest pain, about what imaging is most appropriate in what context. Also, there's also a nice summary of the topic and imaging in each of these documents. This one was for ICU, chest x-rays in the ICU. Wanted to just point out that a stable patient, the second variant, stable patient, no change in clinical status, gets a rating of 3, which is usually not appropriate. So ultimately, this document is saying that the daily ICU is not appropriate without a clinical question or a change in clinical condition per the ACR. Good to keep in mind. This was a study they did in France where they looked at a large group of patients that got the daily ICU, and then also a group of patients that got only chest radiographs when they needed, like an on-demand kind of need, and there's no difference in overall care and outcomes. So what is our role? We oftentimes there is a specific question: do they have an effusion? Do they have an pneumothorax? But for the dailies that do sneak through, it's about 100 or so a day. We are looking for misplaced lines and tubes. We're looking for unexpected findings, large effusion, significant pneumothorax, those types of things. One of the first tricks in the unit is to figure out what is external. You don't have to put all these things in the report, but it's important for you to know what they are, to kind of ignore them. You can mention them if they obscure something. That's important. But ultimately, we just want you to have the knowledge of what they are. So defibrillator pad, trauma backboard, EKG leads. The other nice thing about our integrated medical records is that there is a spot for if you see a line and you're not sure what it is. We have an active lines and tubes tab right here, so you can look down and see what the patient has, maybe correlate with what is what you're seeing. It's a pretty typical daily ICU after median sternotomy and valve repair. If you had a template that said diastolic median sternotomy with left basilar chest tube and mediastinal drain and Swan-Ganz overlying the main PA and left basilar atelectasis, you could probably call that template post-op day 1 ET tube at the level of clavicular heads and just copy and paste that quite a bit. So good normal appearance, and you'll kind of start to put different patients into different buckets as far as this is a good post-op cardiac patient day 1, and they'll start pulling out tubes as we go out through the week. So it's important to know what the lines and tubes are going to look like. This is a typical appearance of our ET tube. As far as where you want that to be, at least 2 centimeters above the carina. I use verbal clues. I don't always measure it, but I'll say something like at the level of the clavicular heads or somewhere between or midway between the carina and the clavicular heads. I tend to, for all lines and tubes, I use the word overlies instead of in. And that is because we can't always tell. One kind of board's question that may come up, or it might be a step 3 question or something, but the ET tube moves down with chin flexion, as you can see in this diagram here. Kind of may see that in multiple choice format. This is a radiograph of right mainstem intubation. Not the clearest to see, but you can see that there. Something you always want to the next thing you want to do is if you have an unexpected call, you want to call the team. A lot of times the films, maybe they're taken at 4 o'clock or 6 a.m. in the morning and you're reading it at 8:30. That person that ordered it might be at home sleeping, so you don't want to page them. But what you can do is log in, launch the patient's chart, hover over this primary team text, and you'll see their pager, this 9433 number. I would advise you paging them, not the listed provider for inpatients. Outpatient's different, but for inpatients, that's more reliable. So a typical tracheostomy tube, I've never particularly seen one or called one to be in the wrong position, but there's one where we'd expect to see it. This is a film where you see the outline of the trachea, and then we have this gas lucency adjacent to the trachea. It says patients in the ED intubated. I was concerned for an esophageal intubation, so I called the ED, and they said, no, he has a king airway in. So then I had to Google that, didn't know what that was. So I learned something. It's an airway that's put in the field sometimes. You can see it. It is in the esophagus, and then the trachea air goes in there. Interesting. So be aware of that device. So nasogastric decompression tube has a thin blue line down it. You see it in person, has a little side hole about 10 centimeters back. You want to make sure that that side hole is below the GE junction, because otherwise you can have gastric secretions come up through that side hole and put the patient at risk for aspiration. That's what it looks like in person. Again, has multiple side holes. We just see the last one has a break in the blue line that is radiopaque. This is a gastric decompression tube in the left mainstem bronchus. That would be something you'd want to call and use the auto text notification that you spoke to somebody in person or on the phone. It's another NG tube in the right lung. That's an arrow at a gown button. That's the outside of the NG tube. So a lot of times the NG tube the tube will be on the inside, but then also come out their nose or mouth and then lay over their chest. So sometimes you'll see the outside of the tube as well. The Dobhoff tube, it looks a little bit different, radiographic. It's used for feeding. The goal is the weighted tip will take it post-pyloric. In olden times, I would be pimping people about who invented it. There's actually two docs, Robert Dobby and Dr. Hoffmeister, not that guy. It's a Dobhoff tube in the right lower lobe. Talk about some central lines. Ideally, central lines, again, I use the word overlies, SVC, or at the level of the cavo-HO junction. HD catheters are going to be a little bit deeper, but there's some people talk about if you have a line in the RA, it could cause arrhythmias or perforate. This is right-sided central line, overlies SVC. This is a left-sided central line that does this little J hook right about here. That's usually indicates that it's in the azygous vein. That's something you want to be aware of and let them know about, or let the team know about. This is a HD catheter, and then a new left-sided central line was placed. We'd expect it to cross midline. It goes straight down. That's a little worrisome. You worry that's in the aorta. Pulled up an old CT, and turns out they have a persistent left-sided SVC. So it makes you feel a little bit better about that. Sometimes there could be a test question that says, where does a persistent left-sided SVC drain? And that is, the answer to that question is C, coronary sinus. This is similar appearance. Right-sided central line fine, ET tube fine, left-sided line. The patient doesn't have a left-sided SVC, so you call them and said, hey, I don't know where that line is. This happened. This was a case when I was a resident. They said, yeah, it's not drawing, but when I flushed it, she started to get hypotensive. So brought down to the scanner, had a pericardial effusion. So the line just went through and through the vein and ended up in the pericardium. Patient coded and expired on the CT table. So scary stuff. It happens. So you want to be aware. This is a left-sided central line with overlies the aorta. Call the team. Got a CT. It was in the aorta. This is a portacath or Metaport, different brands. Sometimes the techs will call you and they'll want to know if it can be power injected. The ones that can be power injected say CT on them. It's upside down. It says CT. This one is a purple power port. It's triangular in shape. They're rated. Some are rated for CT power injection, some are not. This one is, so it's important to know which ones are, because if you power injected one that's not rated and blew this little catheter off the hub thing, that would be bad and people would be upset. Swan-Ganz catheter, this is it here coming in on the right. The balloon tips floated out to get wedge pressures, and then they park it back here. Usually park it here in the PA. Textbooks will say you don't want it further out than 2 centimeters out from the right hilum. I don't know where to start that measurement, but if it was out here, I'd let them know, hey, it's overlies the right hilum. Any further out here, you certainly don't want it left out here. And that's, again, 2 docs invented that. Swan-Ganz coiled in the right atrium. This is intra-aortic balloon pump, IABP. 2 ways to measure these. You can either measure from the top of the arch and 3 centimeters down, or if you think about on the radiograph, the arch being a circle, you want it at the bottom of the circle. It inflates during diastole to force blood into the coronaries. Too high can cover the left subclavian. Too low, you'll end up covering the kidneys. The celiac and SMA can handle not having diastolic flow, but the kidneys don't like it. You can see this one's on CT, quite low. Going to pause for a second here. Okay, back on. We're IABP. You can see it's a little bit low here, pretty low. That's what it looks like on CT. This one's too high, covering the left, could be covering the left subclavian. This is a large pneumothorax on the right, displacement of the NG tube. Again, just a note, if you see a large pneumothorax with shifted mediastinal structures, it's an emergency. You want to know where the patient is. You want to call somebody. Don't wait to check out later with attending. It's an emergency. Other types of chest tubes. So we have some examples of surgically placed chest tubes. Those are the straight ones that have multiple side holes, but the last side hole cuts through the opaque line. So you don't want that to be outside the chest wall. These pigtails, we put those in, other people's put those in. Their last side hole is before this marker. If you need to, if that comes out less likely. AICDs, this is a defibrillator because it has this coil part here, so the shock gets delivered between these 2 coils. There's a right atrial lead, right ventricular lead, and this lead goes out the coronary sinus and paces the left ventricle on the outside of the heart. These 2 are on the inside of the heart. This is kind of a fun case, but sometimes you see it in a board situation. Patients, after this was looks like a single lead placer, pacer was placed, came back, and it was retracted. And what happens is patients will twist the pacer in the pacer pocket and pull the lead back out. It's called Twiddler syndrome. This is a subcutaneous defibrillator. So on the front, frontal you can't tell, but on lateral, you can see it's in the subcutaneous tissues. I don't know why we don't see more of these. Certainly makes a lot more sense than having something inside your heart, but maybe doesn't work so well. I'm not sure. But in case you see those, subcutaneous defibrillator. This looks like a pacemaker, but it goes to the neck. So that is a, sorry, I lost the slide there. This is a neurostimulator. This is another defibrillator. The right ventricular lead kind of takes a funny course. Let's see if we have, it looks like it has a funny course. You say, oh, that's strange. So I looked up in the notes or tried to figure out what was going on, and they have a RA lead and a HIS bundle of his, not his, her lead, but his lead. I didn't know what that was, so I looked it up. Apparently it's a new frontier in the treatment of heart failure. So I learned something, and that was okay. That was where they wanted it. But if you see something you don't like and it's a little, it's a little abnormal, dig into the chart. We're lucky to have a lot of integrated medical record where we can look these things up. So that was okay. This is a clip for a GI perforation. I just hadn't seen that before. It looks kind of scary, so I didn't know what that was. I put that in here. This is a left ventricular assist device, sucks blood out of the left ventricle and pumps it into the aorta. You can't see radiographically the aortic conduit. On CT, it's a little better view here. CT, it's a little bit easier to see. So again, sucks blood out of the left ventricle, goes through this metal thing, which we can't see inside on CT. It has a little turbine, a little thing that spins around and then goes back up and plugs it into the aorta. What happens every once in a while on call, this will get called a layering thrombus, but the conduit is this thin, or this, you can see this is the same width the whole way down. And then this is called a bend relief. The bend relief around this conduit, there's just some dead space in there that gets a little blood or whatever. So don't call that a layering thrombus inside that conduit. Just a pitfall there. There's a little turbine thing that spins around. They wear this little device and it has a number on it so they can see how many revolutions, and the battery pack. Cheney had one, I think, before he got his heart transplant. This was this different type of artificial heart. This is a Jarvik artificial heart. Has these big pneumatic balls that inflate and deflate to pump the blood. You can see that's inflated and deflated. This is what it looks like on CT. I've only seen one of these. So certainly the HeartMate and the other left ventricular devices are more popular. But I thought that was interesting. So median sternotomy, what it looks like before they close. Thought that was interesting. So, and after we close, nice aligned. You always want to be mindful of the alignment of the sternotomy. So this was day 1, and then a little bit harder to see, but say day 4 or 5, this one starts to run away. And so if you have migration of a sternal wire, that's always concerning for dehiscence. You can see that here on CT. So it used to be in a nice straight line here, and this wire stays intact. And the way this question is typically formed is, what is the most common finding? And choices are air in the sternotomy, fractured sternal wires, and migration. But it's migration that you typically see. Choice C. Tiniest little sternal wires you've ever seen. Tiny little surgeon, or no, she had it done when she had congenital heart disease and had it done when she was a kid, and now she's an adult. Just thought that was kind of neat. This is an ET tube that is intentionally left main stem, but there's a little switch. They can aerate both lungs through that switch, and then they can selectively isolate if they're going to do surgery on this lung to ventilate that. So just to be aware of that device. Has these 2 little rings and this little curve to it. And then if you see that little metal density, that's something that you want to train your eye to pick up. So any thoughts? That's a tooth filling. So during an intubation, knocked a tooth out, and that's in there in the airway. So good to let them know about that. I don't remember what this one is. Looks like they have two central lines. One is going way out here. So that's way too far out. This is a line that is going in, supposed to be going down, and goes up. We don't see the end, so I call them, recommend radiographs. They got radiographs, and they said, oh my God. So this is looks like a line that went in the subclavian arm and made its way into the contralateral transverse sinus. Pretty amazing. This was catheter that comes up through the leg and has this little hook thing on the end here. It's called the Impella catheter. Basically, you can think of it as a left ventricular assist device that you insert over intravascular. So an intravascular left ventricular assist device. It sucks blood out of the left ventricle here and pumps it out above the aortic valve here. You can see that here. So sucks blood out here and delivers it up here for, so it's kind of an internal left ventricular assist device. This at first looks like one of those loop recorders, but it's inside the heart. It's actually a leadless pacemaker. It is actually inside the heart. Looks like a bad idea. This was a little proby looking thing. Didn't know what that was. Turns out that is a Bravo probe. It's in the esophagus. This kind of looks like an IVC filter in the heart, which you don't want to see, but that is a PFO closure device. It's a typical frontal and lateral, I believe, from a median sternotomy and aortic valve replacement. This little 3-crown one is a bioprosthetic valve, which means that those patients do not have to be on anticoagulation. The full metal valve like this one, or it looks like 2 little doors, they last forever, but they have to be on anticoagulation. This is a endovascularly placed aortic valve, just so you know what that looks like. That's a graphic of that. This was radiograph I read. I saw this thing, didn't know what that was, never seen that before. I think I asked Juliana, she didn't know. So went to the chart, went to active lines and tubes, and I saw this and said, right wrist illumination ultrasound guidance. So I Googled that and I found this was a TEE probe. So it's a disposable, miniaturized disposable TEE probe. Super sick patients, they'll just leave them down there so they can just like come by and do TEEs and just like plug into it when they want. I asked some friends and said disposable. What do you mean disposable? And I said, yeah, you can throw them away. They cost like $2,000 or $3,000. So it's as disposable as this computer that I'm working on, I guess. Okay, AICD placement. Usually the right atrial lead hangs out over here. This one crosses over. You look at the prior, you're like, yeah, that's usually where I used to see it. So if you see that change, good idea to call. They can go and do EP studies and see if that has broken loose. This, not sure if anyone knows what this device is. Just something external. So this is, suspenders or something. It's great. The indication helped here was aspirated trach brush. Now I know what that looks like. This was a line that looked like I didn't know where that was or where it was going. On CT, you can see it here. Comes in and goes down their left internal mammary vein. I thought that was pretty good. This was another pacemaker one that just didn't make a lot of sense to me. So you have the right atrial lead, the right ventricular lead, and then this one going back here. The only thing I know that breaks out there was the azygos vein. So, oh my gosh, how'd they get that in the azygos vein? And it turns out they did it on purpose. So that was good. Learned about that. About a year ago, they started putting these on patients. There are these little patient monitor things where they would be able to know where the patients were and if they're getting up out of bed and those types of things. This seems, I put it in here. We trialed it maybe for about 6 months, and then all of a sudden it disappeared. So I'm guessing we're not doing it anymore, but just good to know if that comes back around. So I thought this one was good. This one, patient looks like they're in flash pulmonary edema and they're making a phone call. Thought that was great. OR miscounts. Sometimes you'll get a call, you'll see a film come over and says OR miscounts, which means this patient's in the OR. They're not going to leave the OR, but they have their count's wrong. So it could be they have one less needle, they have an extra pair of scissors. So you want to know what these two things look like. These are Ratex, these little squiggly lines, and these are lap pads. You never want to see these inside a patient. So again, the lap pads is blue tape, is this handle right here. And then the squiggly ones are Ratex, they're a little bit thinner, and this blue line here is what we see there. So that is all I have for this lecture. Please give me some feedback on how that goes, and we'll give you cases instead. Thanks.